It is a very important topic for us clinicists because we understand that in the epoch of evidence-based medicine and in large scale randomized clinical trials that affect safety and efficacy, the questions of extrapolation of this data into the population of patients and specifically diabetics is very important. I think I shouldn't speak about it in this audience of professionals. So the data of real clinical practice, RWD, RWE, are very important. Sometimes the question arises, to what extent RCT's work in real clinical practice? There is a boom in diabetes today. It is first of all, it is connected with the development of new options, new classes of sugar-reducing drugs that have cardiovascular advantages. And in the slide, I would like to show the sum-up table of RCTs of anti-diabetic drugs. We have two classes, NLGT agonists and GPP1 showed a very positive effect on the cardiovascular outcomes. So that, of course, concerned the MACE, MI, cardiovascular death, stroke, which are the most primary endpoint in on diabetes trials. And so it turned out then along with the hypoglycemic qualities, they had such a preferential effect in cardiovascular diseases, but they act differently. NLGT, they are shown in blue. EMPA-REG, Canvas, Declare mainly have advantages in such an endpoint as heart failure and cardiovascular death associated with HF for GPP agonists. The advantage concerned the antithrombotic events, non-fatal stroke, non-fatal MI, myocardial infarction. Of course, that manifested in the guidelines starting from 2019. The ADA have maintained this position that prescription of this line therapy, lifazin or GPP agonists should not depend on the final glycation of hemoglobin. So patients who have a risk of anti-sclerotic diseases or have an anamnesis of vascular diseases must get this drug, must get this therapy of drugs that proved their advantage in RCTs. So the question arose, in real practice, from the point of view of the representation of these patients is in line with the inclusion criteria of the trials. And today, many countries, many of our colleagues make such an analysis.
И среди соответствующих событий при сравнении лечения агонистами рецептора глюкагон-подобных пептидазий и ингибиторами натриглюкозных котранспортеров второго типа с другими сахароснижающими препаратами в реальной клинической практике в двух регионах Италии. Это Ломбардия и
In two regions of Italy, Lombardy was one of them in 2010, 2018. I forgot to mention one more important thing. These drugs have been registered since 2008 as SGLT2 agonists, and the studies that have shown the advantages of these drugs actually were conducted in 2015 and even 2010. These drugs were administered as sugar-lowering drugs starting from 2010, GLP-1 and GLST2 were administered also to treat the primary endpoints. Well, you can see the number of patients included in the analysis. Well, in Lombardy, for example, in Lombardy, that's about 19,000, in Vaculia, 9,700 patients, and we can see that GLP-1 receptor agonists in Lombardy is associated with the lower level of death, with the reduction of peripheral vascular disease. In general, it led to the lower limb complication events, which is a very important thing because here we're talking about the need of revascularization, especially when there is critical ischemia. And I said that randomized clinical trial showed that this class of drugs was better in terms of reducing different thrombotic events. Also, they reduced acute coronary syndrome and in general cardiovascular diseases when this class of drugs was used. As for SGLT2 inhibitors, again, in Lombardy, and you can see the number of patients included who were on this therapy, almost 12,000 patients in each group who got SGLT2 inhibitors, and you can see comparison with other sugar-reducing drugs. Well, you can see that as for heart failure, well, there was basically the same situation as in randomized clinical trials. So we got the data from real clinical practice confirming the advantage of GLP-1 receptor agonists and SGLT2 inhibitors, thus confirming that real-world data were true. I also liked the efficacy of GLP-1 receptor agonists and their impact on the body mass and on glycated hemoglobin. Well, you can see the dynamic of HbA1c from 6 to 12 months. And again, that was a positive dynamic. And you can see there was a positive dynamic in terms of body mass index. You can see almost 58% of patients who got GLP-1 receptor agonists had the improved glycemic control together with the drop in the body mass index, which fully complies with the results of the randomized clinical trials showing the efficacy of this class of drugs. Here is another important aspect before I move on to the Russian data. Recently, it turned out that, well, GLP-1 receptor agonist therapy was as effective as basal insulin therapy, and even better. These are the results of the randomized clinical trials. GLP-1 receptor agonists work as good as insulin, except for those patients who have decompensation and catabolic processes. They amount for 20 to 30%. So you can see most patients still get advantage when they get GLP-1 receptor agonists. They should be administered before insulin in most cases, and this was also mentioned in the publications of the American Diabetic Association, and in Russia, the administration of GLP-1 receptor agonists is a very good option before administering insulin. So we conducted our own analysis together with Still Consulting, and our goal was to study the pharmacoeconomic aspects of using GLP-1 receptor agonists in patients with diabetes mellitus type 2, and how GLP-1 can have an impact on the reduction of MACE. And again, these were real world data. Again, that was injection therapy. To what extent the GLP-1 is widespread in the Russian Federation. This slide is a little bit populated. You can see the design of this study. We have a registry of patients with diabetes mellitus, and here you can see what is happening with drug therapy. So we took the registry data. You can see the number of patients with diabetes mellitus type 2, 4.43 million. We basically compared these patients with those who were included in the study. That's the REWIND study and the SUSTAIN 6 leader study. 48% of patients met the inclusion criteria in terms of REWIND. In terms of SUSTAIN 6 leader, 30% met the inclusion criteria, and they have basically the same indications for administering GLP-1. So again, if you look at the course of the disease, there is a time when there is a need to administer injection therapy. So we compared the data with basal insulin and insulin glargine. In particular, insulin glargine is most often administered as an insulin analog. Well, I have already mentioned the meta-analysis. GLP-1 receptor agonist is quite effective. We have serious advantages in terms of better endovascular outcomes. As for GLP-1 receptor agonist, unfortunately, the widespread of this drug is very low in the Russian Federation, so it does not reflect the real value of the drug, the real benefits that patients can get from having GLP-1 receptor agonists. So here you can see, well, different brand names. At that time, Victoza or liraglutide was most widely administered. Well, now the situation is changing. Well, again, you can see dulaglutide is gaining momentum, as well as semaglutide. We have more evidence on the basis of real clinical trials, but nevertheless, you can see the total number of administrations of GLP-1 receptor agonist in general is very low. Well, so out of 4.4 million patients with diabetes mellitus type 2, even 4.6 million, if we look at 30%, well, we understand that that's just several thousands of patients who are on this therapy, but not millions. If we look at the basal insulin, well, we can see that insulin is administered with one global purpose: to manage the glycemic level. So glycemia is also important in terms of reducing the risks of cardiovascular complications. And you can see that the administration of insulin, in fact, well, you can see the HbA1c figures 8.4, and then due to insulin, there is just some minor improvement when the A1C level goes down, but not significantly. So again, you can see the results obtained due to the administration of basal insulin, and naturally, I should say that basal insulin cannot solve the existing problem as compared to GLP-1 receptor agonists. And naturally, well, administering GLP-1 receptor agonist can give us better results. Moreover, you can just have a dose once a week, not every day. And so there is also depot GLP-1 administered once in a month, which can bring us much better results. So the main conclusions drawn from the preliminary analysis of real world data is that the need in GLP-1 receptor agonists is much higher as compared to what we have in the Russian situation. Most patients, 99%, well, the daily dose of basal insulin glargine is not titrated, and well, this is due to poor filling in of the electronic health record, and also because of different fears that we cannot achieve the targeted level of glycated hemoglobin. So our position is that real world data allow us to analyze the situation and talk about the clinical outcome to assess the safety of medical therapy. RWD allow us to make epidemiological conclusions and to see some particular links between different diseases and treatment. And I gave you several examples in my presentation. I should say, as far as diabetes mellitus is concerned, the epidemiological situation here has changed over the last 10 to 15 years. And also, as for the mortality rate of patients with diabetes mellitus, real-world evidence allows us to monitor the situation and make specific decisions, including make organizational decisions to provide care for patients with diabetes mellitus in terms of the optimal use of resources, in terms of optimal medical care, to improve the quality of this care, to expand their access to different treatments. Thank you very much